Hello and welcome to another edition of Cardiac Imaging Agora. In this edition, we will try to illustrate with a case the importance of appropriate use criteria, the AUCs, as well as some pitfalls in reading a SPECT-CT. So this case will point to two issues that are somehow interconnected. So one of the issues in modern medicine is probably the ability we have to test and to do a lot of tests. And the AUC is probably one of the, I would say, a barrier or a tool that was developed to let us think a little bit before we start ordering these tests all the time. So this case again will illustrate the issue of AUCs and following the appropriate use criteria, as well as the importance of following some logical steps before reporting a SPECT or a PET. So this is a 71-year-old male patient who came to me for abdominal surgery for pre-op cardiac clearance. He had a prior PCI with a bare metal stent to the mid-LAD and distal RCA back in 2011. And then he had a drug-eluting stent to the mid-LAD just proximal to a previous stent in December of 2013. He's feeling well, he's asymptomatic. He walks about 3 to 4 miles a day. In kilometers, that's about 5 kilometers a day without any symptoms. He feels in general, as I said, well, except for recent GI issues that he's dealing with. These are his risk factors. He has a history of hyperlipidemia. He's not diabetic. He has no hypertension. He also does some stationary biking with 20 to 30 minutes when the weather doesn't allow him to be outside to walk. So therefore, his functional capacity, estimated at least during my visit, was about more than 5 METs. And he has some issues with non-obstructive hypertrophic cardiomyopathy with a septum of 2.2 measured before. So I start first with the first question. So we have the published multimodality imaging guidelines, which will allow for non-invasive testing in most patients who are not able to achieve 4 METs or graded exercise prior to surgery, prior to a planned non-cardiac surgery. Is this true or false? So this is an important question, and it's mentioned in the multimodality imaging guidelines plus multiple other guidelines. So the 4 METs cutoff is an important one. So think about it for a second, and this is a patient who's asymptomatic. Again, what kind of stress you're going to put this patient through during this surgery? This patient achieves in a daily fashion more than 5 METs, probably more than 7 METs if you count the stationary biking and the fast walking. And now, do we need to do anything else? So the guidelines do not actually suggest that we should do anything for these patients unless they are going for a high-risk surgery. Usually these are vascular surgeries, chest surgeries, or if we have a patient where we think the approach of going for pre-op testing will change the management downstream. Let's say a patient with angina or a patient who is not optimally treated. These are instances where we want to probably test to make sure that we are not optimizing them before surgery. And if you can walk through this stepwise approach to perioperative cardiac assessment, you can see here that if you are dealing with a semi-elective surgery here, and the functional class is more than equal or more than 4 METs, and you have no vascular surgery, you should probably be okay to proceed with the planned surgery. If you're dealing with a vascular surgery, we can get a permission with the level 2A evidence to consider that some testing only if the testing will change the management. Very often, if you think about it before you order the test, you find that the patient does not need the test because the management will not change anyway. So what do you do next? This is what came to, the patient came to see me. I so-called cleared them for surgery. I never use the word cleared. I usually say this person is at acceptable risk for surgery. I usually see patients on Friday, so this was my Friday. I saw the patient. I said he's at acceptable risk for surgery, and usually say further testing from a cardiac standpoint will not alter that risk in any meaningful way. A few days later, I got called from the nuclear stress lab. I was not reading that day. And I was told that the patient has a positive stress test. The same patient, the pre-op surgeon saw him, and he said that he will not operate without a stress test. So here we are reading a SPECT on this patient. This is the stress on top, the rest on the bottom. We're doing this, of course, for issues of QA, making sure there's not much motion artifact, which is a tiny motion artifact in the stress images. Also making sure there is nothing, no abnormalities in the chest as far as uptake that's unusual, indicating some malignancy or tumor or something like that. So here we are, everything looks fine, except for some tiny motion. Then these are the images that I looked at saved in our electronic medical record. Resting image here, stress images there. And you can see on the rest images, you have a mild perfusion defect in the lateral wall compared to the septum. That's not unexpected in a patient who has hypertrophy. This is a scaling artifact related to the fact that the septum is thicker than the lateral wall. As I told you before, this patient is known to have a 2.2 centimeters septal wall thickness on a resting echo. On the stress images, you can see there is almost an eclipse of the bottom part of the heart where, or the bagel is missing the lower part right here, and you can see it here in the vertical long axis. For a reader reading this 99% of the time, this will indicate an RCA, large RCA, and probably some septal even ischemia. But in general, this is a large RCA territory ischemia. These are the gated images on this person, rest and stress. This is actually what was the disconnect for me on this study. I looked at the gated images and I saw there is normal wall motion on the rest and stress images. No evidence of a perfusion defect on the stress images. So I was taken back by that. So I thought about what to do next. And knowing that at our institution, we, on all the stress SPECT images, we do CT attenuation correction. I went back and I told the patient to wait a little bit in my clinic so I can go back and look at the images and see what's this so-called positive stress test, look at the image and see if it's really positive or not. So I went back and I looked at the what we've been talking about in this series, the transmission and the emission images, and you can see here on the transmission images, the heart is, the CT images are here, and the emission images, you can see there is a misalignment of the images right here by the lateral wall or inferior wall. When I realigned the images, this is what we got, rest and stress. So again, rest images here, stress images here, and this is with attenuation correction. You can see here everything aligned perfectly, and that perfusion defect is gone. And here the images side by side. Here's before when we had a misalignment of the perfusion and transmission images on the CT attenuation corrected images in the stress. And here are after the alignment, this defect is completely done. So this is a lesson in one or two things. First is this patient went to the lab despite the fact that the AUC suggested should not be tested. We could have ended up with a semi-disaster, because what we have right now, we have a very so-called positive stress test that's going to lead to a cardiac cath, that might lead to delaying the surgery, complications. We might find something on the cath that is intermediate stenosis or probably more than that, but physiologically not explained. Then he will end up with further stenting and then going on dual antiplatelet therapy, which might lead to delaying the surgery again and messing up his plans. So this is the first step. The second issue here is the importance of reviewing these images step by step and not jumping straight to the final screen where we're seeing the sausage. You want to actually, in nuclear cardiology, you want to understand how the sausage is made. So the sausage is made, and how it is made can be only discovered or unpacked by following these steps that we've discussed before. The first step is to review the transmission and emission images, and then go through all these steps to get there. Now, we don't do flow here because it's a SPECT, of course. But again, the other thing is to look at, if you have a huge defect on the stress images suggesting ischemia, and you don't see that defect on the gated images, make sure you go back and figure out what's going on with your CT attenuation correct images. You cannot have a defect that severe on perfusion images and not see it at all in the gated images. With that, I end this edition of Cardiac Imaging Agora. I hope you're enjoying these sessions as much as we are, and hopefully we'll meet again for another edition in the next few days. Thank you.